good morning, or good afternoon, depending on where you are this morning or this afternoon. Going to let a few of us get settled in here. Looks like there's a few still connecting, and our audience is growing a little bit. Great to see some familiar names and faces. Hello there, Mr. Widow. Glad you could make it. Good to see you, brother. Yes, and I'm seeing some other familiar faces as well. Thank you so much for joining us. Lucy, glad you're on. I see several others that are joining us, and we'll see perhaps too if we get a few more joining. I think we've disabled the wait room, so if folks join a little bit later, they won't be trapped somewhere in Zoom world in the waiting room somewhere. So that's happened on a few occasions. So let's everybody's seeing that full screen. I checked it with Parker. I have my colleague Parker on. He's going to assist us here, just getting started with some of the technology stuff to make sure I don't break anything before we get started on today's topic. And again, I just want to officially welcome you all to another installment of our Essential Substance Abuse Skills training webinars. As most of you know, these webinars, this series of 12 modules is really designed either as a refresher for someone who is currently practicing in the substance use disorder or behavioral health field, or perhaps someone who is getting ready to credential or just entering the field. It also, or our hopes are that it provides you with some good introductory information as you begin your journey in this field. So great to see everyone. My name is Steve Steiny. I'm one of the managers here at the American Indian Alaska Native and the National Center here. We're located at the University of Iowa. And I'm broadcasting to you live from the University of Iowa campus here at the College of Public Health. So again, it's great to see some familiar names and faces, and it's nice to see a few others joining the group as we get ready to start here. So I'm just going to go through a few introductory slides, and then I'll transition and get our main slide deck up. We're going to cover quite a bit. My hope really is to spend most of our conversation today talking about treatment planning and the process, what processes are involved in creating treatment plans for our patients or our relatives as we engage with them in the treatment setting. There are some other areas that we're going to touch on briefly if we have time. One of them is documentation, and also correlating the ASAM criterion into the treatment planning process. Got quite a few slides, so if we're not able to get to the ASAM information, I know that we have addressed this in previous webinars. Remember too, this really is the third piece of this clinical evaluation process. We've talked about screening, we've talked about assessment, and now we're really talking here about this third and final component of this clinical evaluation process, which is the treatment planning. They're all connected. They all sort of have an interrelatedness to them, and we really use that assessment and screening information to help guide us in the treatment planning process. So we're going to touch on that and talk a little bit about that today. So just really good to see everyone, and I hope you're all doing well. I'm fighting off a little cold, so I'm hoping my voice holds up. We'll see how it goes, but yeah, it's great to see everybody. Just again, a couple of introductory slides. I know most of you have heard this before, but This event is brought to you by the National American Indian Alaska Native Addiction Technology Transfer Center. As I mentioned earlier, we're located at the University of Iowa, and we are part of a larger TTTC network that involves a network coordinating office at the University of Missouri, a national Hispanic and Latinx office, as well as 10 regional centers around the country. And as most of you know by now, this project is supported and funded by SAMHSA, and the content is developed by the presenters, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the National American Indian Alaska Native HTC. Following today's event, we are going to reach out to everyone. We'll include a PDF version of the slides we go over today, so you can use these for, hopefully for good purposes, for continued training or review as resources. But we would ask that you just use them responsibly and use your discretion. We'll also be recording today's event and make available to you a link so that you can access today's webinar and share it perhaps with a colleague or someone that wasn't able to be here today with us going over the presentation. So look for that follow-up email. Included in that, you will have an opportunity to request continuing education units. You must request and respond to the follow-up email in order to be eligible to receive those continuing education units. So keep that in mind and watch for that follow-up email. That will really help our center track and follow up with you on receiving your CEUs. And be patient with us. Allow 4 to 6 weeks for that that certificate to reach you. If you are on a time crunch or trying to gather some CEUs before you recertify or for relicensure, just let us know and we'll try and expedite that process. Lastly, in that follow-up email, you will see a link to a very short survey. The survey is not mandatory, but I think Parker will post a link to that survey as well in the chat box, and you can complete that at the end of today's event. You don't have to complete the survey at all, but we would really appreciate hearing from you. Your feedback is very important to us. We've added a couple of short answer options or questions onto the survey as well, so you can put into your own words maybe some feedback on things that you think were done well, things that you thought you would benefit from, as well as maybe some suggestions on how to improve what we're doing. But this survey is also important to our funders. It allows us to continue to provide events such as this to all of you at no cost. So just again, keep an eye open for that follow-up email. And before we get started, I just want to take a few moments. I know we're gathered here virtually today, but we want to take time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 former members of our ATTC team from the Squawky and Winnebago nations. Thank you. Well, again, most of you know me. My name is Steve Steiny. I've worked here at the American Indian Alaska Native Center now since January of 2019. Prior to that, I worked in a clinical setting in a behavioral health services nonprofit center, and spent the last 23 years prior to coming here working directly with patients and also helping to train new clinicians coming into the field to be prepared to help others. I'm a person of long-term recovery, and really have dedicated my professional career to try helping others. And sometimes helping the helpers is just as important as directly helping our patients in need. So just really happy to be here. Just as a reminder, I'm going to take that screen down. Everyone is muted currently. If we have an opportunity at the end, I'm going to try and reserve a little time. We can take some questions. If you have some questions or are interested in some follow-up information, feel free to use the chat box. That's a nice way to communicate any questions or comments that you have. We'll save a copy of that as well, but it's a nice way to have a dialogue between us as we move forward. As I said, I'm going to cover a lot of information. Let's see if I can get this old screen down here without it. Parker's still on, so just in case I break anything, we're going to be fine. Parker, I appreciate your presence, and let's see if I can get this next PowerPoint up without causing any other problems. Okay, there it is. Let's see if I can do a little screen sharing with all of you, and we're going to get started here. Okay, here we go. Now, let me ask, are you guys seeing the full screen? Parker, how's this look?
Swap display.
I need to do a swap.
Yep.
Yeah, let me move this over here. There we go. Okay, let's do that. How about that?
Looks perfect now.
Great. You see, that's Parker's here for us, everybody. So hats off to Parker. I appreciate you, brother. And let's go ahead, and what I need to do now is back up my I really need to back this back up to the beginning. So let's see if I can't do that without. I was reviewing and going through some of this even right before we went on, just to make sure. Look at all this. So you guys are getting a review in reverse. There, wait, almost there. I'm sure there's a better way to do this, but there we go. Okay. So you guys got to see the whole PowerPoint in like 5 seconds. You don't get that very often. So again, we're gonna really be talking about today. I really want to share with you some information about the treatment planning process. The treatment plan, and I'll mention this again as we start talking, but I really want you to think of this treatment plan that you are collaboratively creating with your patients or your relatives or your clients, whichever, those words are interchangeable, but think of it as a living document. And I also want you to think of it really as a collaborative process, and that it's not a one and done. It should be evolving and changing throughout the course of the patient's stay in their primary care, and sometimes beyond, even in a post-primary care setting, in a continuing care setting. As I mentioned too, we're going to also try and touch a little bit on progress notes, and there are some slides on ASAM that if we have time, we can at least sort of use that as kind of a review, and how ASAM criterion can also be part of that treatment planning as we monitor the progress or difficulties the patient may be having during the course of their treatment. So everybody's seeing that screen okay, I'm hoping, but there's kind of an overview. Those are some things I'm hoping we can touch on today. And I hope, my plan is to stay on schedule and leave a little time at the end to field questions or respond to any comments in the chat. So, yes, thank you, Catherine. I'm seeing this. Yes, I appreciate that. Thank you for that. So what is treatment planning? Again, that's sort of the question that we're going to kind of rhetorically ask ourselves as we go through today's presentation, and to really try and assign some details and meaning to that. Just by show of hands, if you can use your hand raise feature, how many of you are currently working in the field and developing treatment plans, comprehensive treatment plans with your patients? How many? Oh, yes, I see a couple there. Sharon, Nicole, Alyssa. Yes, and Michael's using old school hand raising there. I appreciate that. Yep. Yeah. So it looks like there are at least some of you, and I'll assume there's probably others that aren't acknowledging that question that are also doing that. But yes, I appreciate that. That at least helps me understand that there are some of you out there right now that are currently, yes, thank you, Tia, and Lucy, I knew you were doing that as well. So, yeah, so some of this may be review for you, and I would encourage you to add to the conversation in the chat box as we go if you have some other suggestions or strategies that you use when developing treatment plans with your patients. So again, I'm going to reiterate some of this throughout today's presentation as we talk about treatment planning itself. As I mentioned before we really got started, the treatment plan is really it's this collaborative sort of engagement between you as the provider and the patient that you're working with. It's really you coming together with them and developing a plan, a treatment plan. I've also heard it referred to as a healing plan. So that can be interchangeable. Those can be synonymous, but a healing plan, a treatment plan, or as I was trained, a comprehensive treatment plan, we would often refer to it using the term CTP as in comprehensive. So, and then also that the counselor and the patient develop goals and identify strategies or action steps or interventions, if you will, for attaining or reaching some of those goals. And you can see here, I've referenced TAP 21 regarding these two bullet points. TAP 21 is a great resource if you are new to the field and are really trying to build a knowledge base, accessing some of these treatment protocol documents through SAMHSA is a great way to build your library and your knowledge base. So again, let's just some other thoughts on treatment planning. The treatment plan is this living document, and it should change during the course of the patient's involvement in your services. And not always, there's going to be exceptions to that. And it may be also determined by how often you're reviewing the plan and what the patient's needs are and situation is. But also continuing care planning and discussion about this should begin immediately and progress as the treatment process moves forward through this post-admission process. So in other words, I would start doing continuing care or discharge planning day one in that treatment plan. Where does this go after you've completed your primary care? This sometimes is required by some licensure bodies, and it's important to keep that in mind as you develop your treatment plan. Many of you probably operate, with templates where there's a treatment plan sort of template I know in the electronic healthcare system now, the electronic healthcare records often will have templates that are integrated into their electronic health records, and there'll be drop-down boxes and ways to fill in and add to the treatment plan as you move forward. A patient's recovery plan truly begins the day they complete their primary treatment stay. And I mention this because once a patient leaves let me back up and say this. So think about it from a sort of a medical model. When a patient arrives into a facility, there's sort of this surge, this front loading of services. And there's a lot of support, a lot of care, a lot of attention given. And then what happens as the patient stabilizes and improves and starts to heal and get better, what happens? Those services start to pull away. And so the reason I mention this is because sometimes transitioning from a residential setting or a inpatient setting or an intensive outpatient or day treatment setting into a lower level of care, into that post-primary care, can really be the beginning of that patient's recovery. So it's important to have some of these plans woven into that treatment plan, and to have that dialogue with the patient about transitioning back into the community or back into a work setting or engaging with their peers. And then the other thing, and I'll mention this again as we talk about it, but the more that we can involve our patients in the treatment planning process, the more meaning and purpose they will attach to it. So if I'm just telling them, here's your goals, and this is what you're going to work on, they may not have that same level of buy-in and that same level of a meaning and purpose attached to it. Whereas if they're creating these and working with you on creating their goals and their treatment plan, they should attach much more meaning and purpose to that. I hope that makes sense to everybody. Let's keep moving. So the treatment plan should incorporate information gathered from the assessment. Now again, if you have been with me on these two previous webinars, we've talked about this information gathering process, this evaluative process where we're gathering information both collaterally as well as from the patient directly, or maybe looking at previous engagements in services, et cetera, et cetera. The treatment plan should incorporate information that you've gathered up to this point. So it could be the result, those of you using the ASI or working in AccuCare, will know that the ASI is part of that. There can be other instruments, other tools that you're using, but the point is that information you've gathered is going to assist you in connecting with that patient to help discern and understand what their treatment plan should look like. It's going to be based on that interview and maybe several interviews that you've had with them leading up to the development of the treatment plan. It's going to be based on collateral information from sources outside of them. And I've got those listed there. It can be any number of these things. And it's also important to keep in mind, the primary reason they're there, those presenting problems or that presenting sort of issue that is underlying and driving maybe the events that led up to or are directly involved in their treatment engagement this time or for the first time. So we're going to sort of build on this idea of bridging the assessment and the evaluation to that treatment plan, and it's really important. And again, if we're doing an assessment that is comprehensive and that is patient driven, the treatment plan is patient driven rather than program driven. It's going to allow you to have this assessment information and to interpret that and incorporate that. It's integrating, this integrated or comprehensive treatment plan addresses those substance use disorder issues, perhaps the comorbid or co-occurring mental health concerns throughout this concurrent treatment process. And, again, addressing those primary needs are absolutely paramount. So, if I'm trying to do a treatment plan or develop a treatment plan with a patient who is still in the process of detoxification, it may not be the right time to begin that treatment planning process if they're still going through some protracted withdrawals. It's important to address those pressing needs first. Evaluate patient motivation to address their substance use disorder. This can be a little tricky, but there's certain components you can use, such as the stages of change model or ASAM criteria to help address the readiness to make changes. This can dictate and can influence the type of goals that you have. I mean, I think probably the most obvious would be, and this is, let's just face it, most treatment centers are abstinence based. But I know from my experience working in a clinical setting that there were an occasion where I would have a patient who was perhaps self-referred and abstinence was not their goal. They were not ready to completely quit, but they wanted to cut back or reduce. So their motivation to address their substance use would be different than someone perhaps who is mandated or more motivated and has more consequences related to their use and are more ready to develop goals to address that. I hope that makes sense to everybody. Identify treatment goals and target behaviors. Again, this is, I know we had templates that would have suggested goals, sometimes to help patients think of examples or goals that maybe previous patients had worked on or that were common to that particular level of care. But it really should be, those treatment goals, again, should be really identified by the patient and associated to certain behaviors, certain target behaviors for change and behaviors that led up to it being a problem or an issue with them. Select interventions for achieving the goals. And again, interventions, we can also, I like to plug in the word action steps or, having certain things they can do that are, we'll talk about, having goals being measurable and attainable, but having those interventions or action steps available. Having a goal is great, but if you don't have the means that you can identify and that the patient can say, here's how I'm going to achieve that, it just sort of remains as this vague goal. Choose measures to monitor outcomes of goal setting. And again, this can be done sometimes simply by putting a specific date or time that the goal, they would like the goal to be achieved. That can be one way to do that, one way to measure that. How will we know, when this goal has been achieved? How do we measure that? And then also to follow up and modify treatment plans as necessary. And, we've talked about that early on. This is a living document, so it should be modified and adjusted as you go through this process with the patient. So treatment planning, at a minimum, the treatment plan addresses the identified substance use disorders as well as sort of those peripheral issues related to that substance use disorder. It can, we know it can impact family relationships, relationships with significant others, employment, education, spirituality, etc. health and legal are also things that we know this the substance use disorders can directly impact. So the treatment plan, at a minimum, can help target and look at some of those impacts that the patient's substance use disorder has had on their quality of life. So again, I'm going to use, we're going to go through several sort of components to keep in mind as you develop a treatment plan. And those of you that are doing this already, feel free to chime in and offer suggestions. But sometimes the treatment plan, is the requirements are sometimes driven by the level of care, or maybe your agency has certain expectations about what format or template you use. But in general, again, we want to look at all of that assessment information that's relevant to the patient's treatment plan. And this is why we've gathered this information to help guide us through this goal setting and potentially help the patient achieve some level of change in their lifestyle choices. And here, using the stages of change can sometimes help guide us as well. And those of you that are familiar with the stages of change know that this can be a way for you and the patient to identify, or they can self-identify, how ready they feel they are to make changes regarding their substance use. And we know that not everyone that comes into treatment is ready to do this. So the stages of change can be a nice objective tool for assessing readiness to change. Anyone using stages of change in their treatment programs currently? Anyone familiar with the stages of change? Yes, Nicole's chiming in, and Michael, I got a hand from him. So again, we're not going to spend a lot of time on this. If you're interested in more information about the stages of change, it's out there, and I have some resources as well if you're interested. But the idea is to use all relevant information that you have to help develop that treatment plan. Another component is to really share with and be open with to the best of your ability. And this sometimes isn't always possible, but trying to be open with the patient about the information that you gathered in the assessment, and to try and involve significant others in the treatment process. So things like looking at confidentiality regulations, looking at various ways to connect and communicate with the patient, factors that might be affecting the patient's ability to understand what you're trying to share with them. Sometimes you can't use a lot of the clinical lingo. You really have to speak plainly and openly and reword some things. And then just the roles and expectations of others involved in the treatment process. So again, one of the first questions that I might ask in a series with the patient is, what does your support system look like? And trying to understand that may influence and impact at least one, if not more, goals in your treatment plan. Provide the patient and or significant others with clarification and further information as needed. So again, looking at ways to assess and involve the patient's support system, whether it be family or peers or other services outside of the agency that you're working with, whether it's engaging them in pro recovery or pro social services or activities, or directly involving family or friends in the process. And then also just looking at the treatment implications in collaboration with the patient and significant others. So again, trying to look at the different levels of care and services available, considering, especially when you're considering a step down or maybe an increase in level of care, and looking at, cost and resources. This is really important in the treatment planning process as well. The effectiveness of various treatment models based on current research. So again, trying to follow best practice principles and engaging with the patient in that regard when developing treatment plans and course of treatment, including goals, and then implications of various treatment alternatives, including no treatment. So again, there may be times when you are thinking outside of the box, so to speak, and looking at other ways to engage the patient in a recovery process that may not be a standard treatment approach. These kind of things come up, and it's important to be prepared for that. That possibility, thinking outside of, sort of the Western way of engaging in treatment. We could probably spend, a whole webinar talking about things related to that. Again, I'm using the stages of change as kind of this idea, how ready is the patient to engage and talk about change, or setting goals, or moving forward, making adjustments, or reevaluating their own lifestyle choices. But to confirm this readiness of the patient and of, significant others to participate in treatment and to move forward and develop, having some of that discussion about making changes. If a patient is in a pre-contemplative stage, for example, which, what do we used to call that in the old days? We called that the patient's in denial. That's sort of an old word that we don't really, in the current sort of vernacular, we're not using that word denial anymore. It's sort of shame-based and sort of can be real confrontational. So using a term like pre-contemplative is just simply saying that the patient is not ready to change because, why? Because they don't believe there's a problem. So somebody in a pre-contemplative stage of change, for whatever reason, I may need to adjust my treatment planning with them, as opposed to someone in a preparation or action stage that is committed to or already in the process of making changes in their lifestyle choices related to their substance use. I hope that makes sense, but it really can be an important component as you are working with the patient, depending on how ready they are to make changes. So prioritizing patient needs in the order that they will be addressed. So again, this can be tricky as well, but I think it's important to involve the patient. Simply, a question very simply can be, what would you like to work on first? Or what would be an important, what would you like to address first? Or what's something that's important to you to work on, in the immediate? And this can be based on things that are related to basic needs. How many of you have had patients that come into your first session and the first thing they say is, I don't have anywhere to stay. I'm on the streets, or there's food insecurities, or there's safety issues. I mean, these kind of patient needs can be very dominant in your relationship, your therapeutic relationship with that patient, in assessing what needs to be addressed first. So I hope that makes sense. There can be a lot of ways this sort of manifests, but it's important for you to be open to that and not feel like you've got to push them in another direction. If I'm talking about someone who is has shelter and food insecurities about the importance that they don't drink or use. And I'm placing that because that's on my agenda above some of their other basic needs, then that treatment plan is really going to maybe not mean as much to that patient, and they may not be ready to engage with you. I hope that makes sense. Number 7, formulate mutually agreed upon and measurable treatment outcome statements for each need. So again, looking at the readiness to change. Where is the patient in their readiness to change? Looking at treatment needs for specific needs for your patient's population, or for their specific needs related to community or to culture. And then how to write measurable outcome statements. And again, this is something we'll talk a little bit about as we talk about, I was trained on SMART goals, but we're going to talk about another format that's similar to that when you are creating treatment goals that you can identify and document measurable outcomes on those goals to help advocate for your patient, to help support their continued recovery and healing. So I'm going to take a quick peek at the chat here. Yes, Catherine. Yes, and sometimes those hierarchy of needs can be different depending on one's culture. I've talked with some of my Native colleagues, and they've often referred to as this Maslow's hierarchy of needs being inverted in Native culture, where it's really about the community rather than self. And so it's something to keep in mind when we're talking about this hierarchy of needs. But basic human needs like shelter and food and safety, I think can transcend some of the cultural differences as well. So let's keep moving. But yeah, so underneath number 8 here, you see identify appropriate strategies for each outcome. So again, these intervention strategies, or what I like to call action steps, or sort of the steps by which the goal would be achieved, are really important. And to look at the levels, or the level of the patient's interest in making changes. Again, we go back to this idea about how ready is the patient to address this. If this is a goal that they've brought up, or is it a goal that I've sort of imposed upon them? And it comes back again. We look at our assessment information. We look at how ready they are to make changes. And we also look at some of those other underlying issues that may be influencing the goals and the things that they want to address first or initially. And then treatment issues with diverse populations. This can also be important to keep in mind if you have a patient who is Native American or Alaskan Native or African American or Latinx. There may be cultural components to some of their treatment planning that is really important to consider. And I know some of you who are working with Native American or Alaskan Native patients. If we had some time, I would open the mic and have us, address some of those. And but it's important to keep some of these things in mind as we develop our treatment plans. Spirituality, for example, may be a very strong component in a patient's treatment planning, and it may not be reflected in another patient's. So it's important to keep some of these things in mind as we work with our patients in developing the comprehensive treatment planning or healing plan. coordinating treatment activities and community resources. Again, I know in the clinic that I worked at, our residential clinicians, they spent a lot of their time trying to access and engage their patients in resources outside of the primary treatment agency, really preparing them for going back into the community. So really being able to incorporate community resources and connecting patients with pro-recovery or pro-social supports, and services that will address maybe some co-occurring issues. But this can be this can be challenging. It can be time consuming, but it's important to we can use the treatment plan as sort of a platform to help both you and the patient organize and prioritize the importance of engaging in the resources the community has to offer, especially related to their recovery and their healing. So develop, with the patient an acceptable plan that you both agree upon of action and outcome, so that you can monitor and evaluate their progress. And this can be done, collaboratively. This can be a dialogue as you build rapport. If you have the opportunity to build rapport, sometimes we don't. Sometimes, I know in our extended outpatient program, it was really a psychoeducational experience where they were not really going to be able to take a deep dive into their treatment goals. It was more, you just skim the surface on those. They might meet with their individual counselor, twice, and then they're attending group the rest of the time. So that'll impact, how deep you go into the patient's treatment plan as well. Yes, I appreciate that. Is it Chenoa? Yes, I appreciate that. I'm going to check that link out. Thank you.
Can you hear me? It's Shanoa.
Chenoa, thank you. Thank you so
Yeah,
much.
no
I was
problem.
close, but I knew I wasn't going to get that one right. I appreciate that link. I really do. And thank you. Thank you for sharing that. So again, looking at the relationship among problem statements and desired outcomes and treatment strategies. So again, we're turning to the patient. How will we know when this goal has been achieved or some progress has been made? And getting in their own words, how they'll know that. Well, I'll have a better relationship with my son. We'll spend more time together. This could be an example of how we would be able to measure whether or not a certain goal is progressing or progress has been made. Short-term and long-term goals, just as a general rule, short-term is sort of identified as 1 year or less, and long-term is identified as a year or more. That isn't set in any specific terms, but just to give you an idea of long-term and short-term. Sometimes short-term can be in a much smaller window than just a full year, calendar year. It can be a few weeks, or it can be really set on the time that you'll be working directly with the patient. But long-term goals can be something that can be extended and transferred into a primary, a post-primary care, like a continuing care setting, and can stay with the patient well beyond the work that you are doing with them. And then just also looking at the methodology that you're using in the evaluative process of progress on treatment goals. So making sure that there's some consistency and some objectivity, and again, that it's a collaborative effort that you and the patient and sometimes maybe a supervisor or the agency is also they have some investment in patients doing well and want to see them continue to progress in their healing and their recovery. Again, inform the patient of confidentiality and program procedures that protect them and the expectations imposed by the regulations. So again, this is a part of that treatment planning, to know that what you talk with them about, the treatment plan itself is protected both federally, and state laws, confidentiality laws protect this information. And this can vary depending on state or federal or tribal jurisdiction, but it's important that they know that it's safe, and the goals you're working on with them and their treatment plan is protected under confidentiality laws. Also, to reassess the treatment plan at regular intervals. We've stressed this throughout, that this is a living document, and that there should be evidence that those goals are being changed or are being addressed, and maybe even modified as goals are achieved, or the patient's needs or their priorities may shift during the course of the treatment, especially if you're working with them on a little longer term basis. I wouldn't expect to see a lot of change in an entry-level outpatient experience, but I would expect to see more changes and more modifications in higher levels of care, or with lengths of stay that perhaps are a little longer. But for the most part, you want to evaluate treatment and that progress in recovery, and then review and revise the treatment plan. Again, this is in the interest of the patient. It's a great way to advocate for them if they have a third party, they have maybe a PO or a family member or an employer that says, well, what's been achieved during the course of treatment, and then you and the patient can say, this is what I've been working on. It's a great way to advocate. And I did that a lot with my adolescent and young adult patients, who really were always on their back foot because no one really believed in them, and no one thought they could make progress or make changes. And so it was a great way to advocate for them and the changes that they've made. Remember, generally a treatment plan would be reviewed or updated anywhere from every 7 days to every 30 days. And it really is, it's dependent on the level of care. I know a lot of states require that a treatment plan be developed within a certain time frame after admission, and then reviewed periodically during the course of the patient's engagement. It really depends on the level of care, though. There's some open-ended sort of review expectations for an extended outpatient or an entry-level outpatient engagement versus higher levels of care like intensive outpatient or a residential or inpatient stay. So let's take another look at treatment planning. Again, I can't stress enough, the more we involve our patients in developing their healing plan, the greater meaning and purpose it will hold for them moving forward. It's just, if nothing else, it really encapsulates the true meaning of this sort of person-centered or patient-centered care, treatment care. Involving them in what's happening, what will happen, and being open and transparent about that will really help them open up and be connected with you in a way that can sometimes be difficult to achieve. Let's see, I'm trying to check the chat again to it again. Okay, you guys are still sharing information about hierarchy of needs. That's great. I love this. If you guys keep talking to each other, it's great. I won't take offense. The more you guys are talking, the better it is. That means you guys are exchanging resources and information. Treatment plans are often misunderstood as being what? I mean, we hear about this. Oh, I got to do a treatment plan. The treatment plan. I haven't done one yet with the patient. It's like this sort of burden, that we have, and it's really important to understand that why we think this way. Well, they're they are very meaningful. They have a significant importance, and they can be, really time consuming. If you've got a heavy caseload, developing treatment plans can be that can be a lot of commitment on your part time wise with those patients. Sometimes they say, well, we developed a treatment, we never looked at it. I developed the treatment plan, and according to the chart, this treatment plan was never looked at again. Or this idea of cookie cutter, it's the same plan. It's this sort of the generic treatment plan, just has a different name and date plugged in there. So these are some of and I'm not faulting anyone, in this regard, but these are some things that are often misunderstood about treatment plans and some of the things that we see. Again, treatment plan goals may look very different for a patient at this entry-level outpatient experience compared to someone in a 30 to 60 day, residential stay or residential program. Those treatment plans are going to look different. It doesn't mean they can't be reviewed and modified and measured, but they're going to look different. A patient's age and gender, maybe their drug or drugs of choice, their cultural background. All of these things and many other things will influence the goals and action steps that a patient brings to a session. So, and that's another question. If we had more time, I would say, what other factors influence, treatment planning goals? It's a great question. And as I've mentioned, lower levels of care of that treatment plan, you may not be able to take as deep a dive and explore as much because you're really just kind of touching on a few things, base goals. Again, I would rather have one or maybe two really good goals than, 6 or 8 sort of goals that we never really get to. So the idea of kind of quality, over quantity can be something that to keep in mind as you're developing treatment goals. Other things to consider, from an organizational or agency standpoint, information requirements of funding, managed care. Is there duplication of information collected? Is electronic health records being utilized effectively? Is there documentation being used effectively in the treatment planning process? These are all other things to consider, and there's probably a couple of other things I could add to here as well. So again, I kind of alluded to this earlier, but if we think about the field of substance abuse treatment, that early work, treatment plans were often program driven. They were often kind of one size fits all, these sort of templates that didn't change much. And this idea that the agency knows, agency knows or the state knows what patients really need, what goals they need to have, and what their treatment plan should look like. That was sort of in the early days. And again, I'm not knocking it. It's just, it is what it is. And we've seen this idea of program-driven plans really sort of de-emphasizes the patient's needs and what they'd like to work on, and rather it's sort of overshadowed by it needs to fit into this standard treatment program sort of milieu or regimen. The plans often would include only standard components, and there would be little difference, among the patient's treatment plans, that cookie cutter idea. Using things like the patient will, remain abstinent. Again, abstinence, even though most programs are still abstinence-based, this idea of harm reduction is becoming more relevant now. So abstinence is not always a goal. But these are just some examples here of program-driven plans. Attend 3 AA meetings a week. Well, we know that AA is one of many paths that a person can follow in their recovery journey. So to implement sort of program-driven, if you have to read the first, 164 pages and complete X number of steps before you can complete the program, that's program-driven. Those are program-driven treatment plans and goals. So that's just an example of some program-driven plans. It often will include only those services immediately available in the agency, and often it will not include referrals to community services outside of the agencies, like parenting classes or mental health counseling or family counseling. This idea, this shift to individualized treatment planning is really important, and this is where we see more options being available. There being sort of a customization to fit the patient's needs and situations and what they would like to work on. This idea of a living document, that it's not just developed and then set aside, but that there's a deliberate and mindful review and incorporation of what the patient wants to work on into their treatment stay. And it's based on patient feedback, and it is, if it's possible, to put it in their own words. I remember I had an adolescent patient, and one of their non-using activities that they were going to try and incorporate was chilling and grilling. And I had to clarify what that was, and I had an idea, but we typed into their treatment plan chilling and grilling. And that was in their own words. And what a great way for them to see that is part of their experience and part of their part of their goals in their own words. So I like that. I like that idea, and I remember how important it was for the patient to see, in their own words, those goals. Let's keep going here. So an individualized plan, it's developed to match patient issues, concerns, situation, and needs. I mean, that in a nutshell, in a perfect world, we can do this with each patient. Sometimes it doesn't always work that way, but should be our goal behind an individualized plan. To individualize a plan, what information is needed? Well, as I mentioned, there are some really good templates that often are interfaced with an electronic health records system. Oftentimes an experienced therapist will develop a menu or an adjustable list of goals or action steps based on previous patients that they worked with. And again, some of those electronic health record systems will self-populate. They'll incorporate the diagnosis into the treatment plan and help generate some goals that are associated with that particular substance use disorder. That can be really beneficial to help getting some ideas started, but again, you're using information you have based on your assessment. This assessment is serving you now and helping you connect with that patient and develop and act as a guide for developing an objective, important, and appropriate treatment plan. Again, to individualize a plan, what information is needed. We continue with this. There's just some different suggestions here, and I'm sure those of you that are developing treatment plans currently can identify with some of these things. we want to involve and look at as much as possible to make sure that we're getting a very holistic, or as we're going to see, sort of this biopsychosocial perspective. And it's absolutely important because the patient's going to have things that they want to work on, and our job is to help guide and collaborate and help connect those things to why they're in treatment in the first place. And it can really be a meaningful process for the patient. They may need help connecting some of these issues to some of their goals, and that can be your job to help them. You can look at this information that you've gathered with them throughout the course of their treatment up to that point and help them understand and connect the importance of why this goal is in their treatment plan and why they've identified that. So again, this sort of is the key here. This holistic approach is a responsible way to review patient needs, strengths, and their goals. Again, asking ourselves, does the patient have a car? That could be a very basic, do they have transportation? Can they access public transportation? Can they get around? That would be looking at sort of their social supports. How closely do they live to the treatment center? I can't tell you how many patients would call me and cancel at the last minute, and what would they tell me? I don't have a ride. I can't get there. I can't get anybody to bring me. And are they being exposed to? Are they living in an environment that is non-supportive of recovery? Some of the most difficult cases I had were youth and young adults who were living with parents or primary caregivers that were using around them or with them. It can be an extremely difficult dynamic to address. So these are some things that we would look at and take into consideration when we're looking at developing that treatment plan with our patients. So again, taking the domains, the problem domains from the ASI and combining those with the biopsychosocial model, we can see looking at medical issues, looking at psychiatric or mental health or mental wellness, and looking at family, peer, or social supports, or social networks. All of these things can be taken into consideration. Why make the effort? Well, it allows a platform for you to develop an individualized plan with your patient. It may be based on a template, but it really can be in the patient's own words and really driven by the patient's priorities and what they want to work on. It leads to increased retention, which we know if a patient stays in treatment and follows through with their continuing care or their follow-up care, they're less likely to be readmitted on a new admission or restart treatment. It empowers the clinician and the patient and focuses the counseling sessions. It really can be that sort of go-to, that kind of framework that you circle back to with the patient and keep them sort of focused and moving forward. Provides the patient with an attainable framework for which to build measurable recovery objectives. And again, it can be a great way for the patient to say, look, this is what I've been working on, and to show this to others and share this with others that are involved in their treatment process, whether it be a PO or a spouse or an employer. Why make the effort? Well, again, individual treatment plans is this idea that it fits with the patient's needs, not with the program's needs, not with the agency's needs. And looking at the Addiction Severity Index, the ASI, like measurements, the ASI items are used to fit the patient's services to his or her needs. So again, we're using our assessment information to best match the patient with not only their level of care, but what's important for them to work on during the course of their treatment stay. But the ASI is an excellent guide to patient needs based on severity scores that can be used as objective measures. So what is included in any treatment plan? Now, I know that we've got about 20 minutes left, so I'm being mindful of our time. So I'm going to try and move through these treatment planning slides as quickly, but as responsibly as I can. We may not get to talk about ASAM, and we can touch, maybe if we have time, we can touch upon progress notes and documentation. But I wanted to make sure that I had enough time to go through the treatment planning process with all of you. Those of you that are already doing this, this is just probably a refresher, but those of you that are learning about this for the first time, the treatment plan is absolutely vital, and it's a requirement, but it's also this platform, this living document that you create with the patient, that they will attach meaning and purpose to if you allow them to do that. So let's look at what's included in any treatment plan. Well, you're probably going to have a problem statement. This will be information from the assessment. So how is it? It's usually the presenting problem, I think, is how it was phrased oftentimes in an assessment tool. Goal statements based on the presenting problem, objectives. So those things, those action steps, those strategies or interventions that the patient will engage in to achieve the goal. And interventions can be action steps that the staff will take, and it can be interchangeable with what things that the patient may do with your assistance. So again, treatment plan components often consist of this presenting problem, which is based on that information gathered at the time of the assessment, goal statements. And we really want these to be, problem statements, and that they're achievable. We want these goal statements to be have some element of reasonable achievement possibility. We want them to be the objectives we want those to be what the patient will do, action steps, and interventions can be what the patient or staff will do to work together to achieve that goal. So there's always exceptions. Most treatment programs are abstinence-based. We've talked about that. But remaining alcohol and drug-free default goals or objectives for the patient in early recovery services can really be something that will make sense to the patient. Maintaining abstinence during the course of their treatment can be a standard goal that can be built upon and defined and made measurable and specific. I often would do this with especially younger patients, where I wouldn't ask them to remain alcohol and drug free for an extended period of time, but to consider remaining alcohol and drug free while they were engaged in services, and then reevaluate. We could add that, reevaluate at the end of treatment, and really it's up to them to decide whether they want to continue with that or not. That can change the element of that goal. Yes, exactly, Catherine. Conceivable, achievable, and measurable. I like that. Yes. Perry, we'll make these slides available in a PDF format. We'll send those out to you guys in a follow-up email. So we're good to go there. So the idea of reducing one's use or cutting back, this can be that harm reduction approach that could be in a viable treatment plan. So Sometimes we sort of default to this abstinence-based approach, and that all treatment centers or all treatment goals should be abstinence-based, not necessarily. So allow yourself to think outside the box, match the goals with what the patient is sharing with you. If they're on the fence, if they're ambivalent about remaining abstinent, try and work with them on a meeting in the middle. Or utilizing, creating some discrepancies. You say you want to continue using marijuana, but we know that your probation agreements aren't going to support that. So what can we do? How can we modify this goal so that it also keeps you, compliant with your referral sources expectations? I mean, these are great conversations to have and can be incorporated into those treatment goals. You want to have patient strengths are reflected in the goals, and that the participants are involved in the planning, that this is documented. So in your note, you would say, the patient and I reviewed goal 3, action steps 1 and 2, and we talked about, him or her becoming employed by the end of next week. So I'm just making this up, but being able to show in your planning, your discharge planning, and your review that that there's a collaborative effort going on between you and the patient. So considerations in writing treatment planning, and also these are just some things to keep in mind. Problems identified are included regardless of available agency services. So, if a patient is interested in X, but your agency doesn't provide X, that you need to be able to help them connect with a service that can help them move towards that goal. Include all problems, whether deferred or addressed immediately. Each domain should be reviewed, and a referral to outside resources is an acceptable way to address the problem or the issue that the patient has. That can be incorporated into that treatment plan. It can be specific, it can be attainable, and it can be measurable. Again, tips on writing problem statements. Try and avoid, try and be non-judgmental. So avoid judgmental sort of language. Stay away from jargon. Things like patient is in denial, or patient is codependent, or patient is unaware or clearly has no understanding. Try and stay away from those kind of statements in writing, the issues and concerns that the patient may have. Use complete sentences and be as clear and upfront as you can. So here's that format. Again, I was trained on SMART. It's sort of a version of this, but how to write an objective intervention strategy or treatment goal would be to use this idea that they should involve measurable, attainable, time-specific or time-limited, realistic, and specific language. So if you can use this or a variation of this to help create some of those goals. So if a patient says, I want to get a job. Well, that's specific, but let's apply some of these other pieces to that goal. And you can really make that very specific. You can make it time sensitive. You can, if the patient says, well, I want to be the governor of the state of South Dakota, I don't know if that's a realistic goal. Maybe the mayor. Let's start with the mayor. What would it take to be the mayor of Rapid City? I don't know. I'm making stuff up now. But the idea is to use some format. There are a lot of different formats for guidelines for writing up goals or intervention strategies. And this treatment matters is one format. So again, we don't have to go through these, but just measurable would be one, attainable, time limited. Again, it can be something as simple as upon completion of treatment, primary treatment. If a patient agrees with me to remain abstinent during the course of their treatment, that's one of our goals. We can make it specific to the completion of their treatment or completion of their probation supervision time. We can add specifics onto that. If I make a goal with the patient to remain abstinent for the rest of their lives, that is it's not real time limited, although it is, but it can be overwhelming. And if we apply some of those earlier, some of these earlier statements, it can be overwhelming and lead the patient down the wrong path. Realistic, I think that's pretty self-explanatory and specific. So using specific language, try using the patient's own words, or perhaps asking for clarification from them when creating some of these treatment goals. So again, here's just some guidelines on these different criterion. Pretty straightforward, and I'm sure some of you that are using treatment or developing treatment plans. Yes, that's a good one, Doug. How are you communicating at home? Yes, and the boarding school experiences. Yes, that can impact that dynamic for sure. I appreciate that. I appreciate that. Well, my voice is holding up so far. I think we're just kind of nearing the bottom of the hour, so I want to try and at least move to the end of these slides. Yes, that's a good point, Catherine. Yeah, conceivable as opposed to realistic. Is that what you're kind of thinking about? Yeah. Okay. So again, the treatment plan review process, this really starts with the completion of that assessment. You're gathering information, you're identifying the presenting problem or problems, you're prioritizing those issues, developing goals to address those issues, and then creating those goals that follow that idea, that matters, or that SMART sort of idea. And I know there are other formats and other guides you can use to developing goals that are measurable and specific. But that's sort of some things to keep in mind when you talk about treatment planning and how it is created. Just want to run down the 5 components of an effective treatment plan. Obviously, the goals are a big piece of this, and we've talked about making sure that they are prioritized, and that the patient is really able to communicate with you what they would like to work on. And if they're not able to articulate that, or maybe not ready to do that, you can be there to assist them, or to say, it's okay. Why don't you give that some thought? We'll come back to that. And you can document that the patient's giving some thought to goals, and that they're going to begin to address that in the next session. Active participation. Again, these are some things that that you would want to see in a treatment planning process. I've had patients that just simply are not into it and just keep saying, I don't know. That you have to be kind of prepared for that. And my tendency was to try and then create the treatment plan for them. And that, that can be problematic. That can go against everything we've been kind of talking about. But it can be important for this can be a discussion about how important it is to get their feedback and for them to be actively involved in the process. Yeah, so again, fighting off that tendency to want to just do the treatment plan for them and to fix everything. That's as helpers, we sort of instinctually want to do that. So you have to be mindful and make sure that they're being actively involved in the process. Support, is another aspect of treatment planning. Is that, that private practice setting is the client support system. It's not just you, but it's it's the world around them and where they're going back to and what their supports look like, and being able to identify and target some areas that they want to improve on, or areas that they need to maybe address that are lacking in support. Outcomes, again, wanting to be able to measure. How will we know that progress is being made? How will you know that this goal is achieved? That can be done in a very empowering way, and you can incorporate that into the treatment planning as a means of measurement or outcome. And again, patient involvement. This is an ongoing conversation throughout treatment. Treatment isn't something you do at the first or second session and then forget about it. It's an integral part of the counseling process. It's a clinical discussion that's simply put on paper and to provide a clear outline and a clear understanding of the direction you and the patient are moving towards. And the key is to keep that patient involved in the dialogue and keep them involved in the process. The more we do this, the more meaning and purpose they will have attached to this process. Okay, we are just at the bottom of the hour now. I've got some other slides that you can take a look at regarding documentation, as well as consideration of ASAM criterion in the treatment planning process. You'll be able to look at those in the PDF form of these slides. And what I may do is go back and consider whether or not to include the rest of these slides in a different presentation, because it's just a lot of information to cover in 90 minutes. But you will have access to that. Yes, Perry's making a comment here. Yeah, and I agree, Catherine. Yeah. And Perry says, I found out that whatever they set their minds at, I'll try my best to support that. Yes, yeah, exactly. I mean, you can be part of the solution, and the treatment plan, the goals, or that treatment planning process is really just the vehicle to do that. And it can be a great way for you to collectively come together with your patient and work on a kind of a common purpose or a shared purpose. So I agree that sometimes is your biggest role, is to just be there as a guide rather than the fixer. So as I said, there's probably 20 slides or so left in this deck. I'm gonna hold off though, since I want to respect everyone's time, and we are approaching the bottom of the hour. If you haven't had the opportunity to fill out that the short questionnaire, that is fine. You'll have another opportunity to do that when we do a follow-up email. And remember, if you want CEUs for this, you must request those when you receive that follow-up email and respond to it in that way. And then give us a little turnaround time. If you are pressed for time on getting those CEUs in, just reach out to me or anyone here at our center, and we'll try and expedite that for you. But wanted to just say thank you to everyone for staying with us for this last 90 minutes. That was a lot of information. I really appreciate those of you that are doing this work already, and those of you that are interested in doing this kind of work. Boy, it's a very, very important field to be in right now more than ever. So thank you so much. Are there any closing comments or statements or anything else anybody else wants to say before we conclude? Well, I just want to say thank you to everyone for coming on today, and until next time, please stay safe, stay healthy, and stay connected, and we'll see you again very soon. Next month, we're going to be doing a broadcast on referrals, and that we'll do another ESAS broadcast on referrals and issues related to that in our profession. So thank you again, everybody. Until next time, we'll see you then. Dokcha.